Yeah, good afternoon, everyone. We have reached the parallel session 3. Welcome to this session on research oversight from ethics committees to redefining research ethics. We have with us Dr. Amar Jasani, who is an independent researcher, teacher in bioethics and public health. He is the editor, Indian Journal of Medical Ethics, and one of the founders of the Forum of Medical Ethics Society. He has served in various research ethics committees. Sir, I am happy to have you co-chair this session with us. I am Dr. Mary Joseph, member of the Institutional Ethics Committee, St. John's Medical College. Research oversight is primarily carried out by institutional ethics committees. This oversight is necessary to protect human participants, ensure informed consent, prevent exploitation, especially in the vulnerable population. With the advent of contemporary research, there are more challenges, and we have to redefine this research ethics. To remain relevant, research ethics must evolve, must include participatory ethics, context-specific oversight, and must also look at data and digital ethics. So we'll start this session by the paper presentations by the three participants here, keeping in mind our theme, ethics education, an imperative for future generation. Each presenter will have 15 minutes, followed immediately by 5 minutes of question and answer session. I call upon Dr. Savitha D, Professor and Head of Department of Physiology at St. John's Medical College, Member Secretary at St. John's Medical College. She'll be presenting a paper on experiences of faculty and postgraduates on informed consent process from 2 tertiary care medical teaching institutions. Dr. Savitha.
I'm Dr. Savitha. Good afternoon to all. I would be presenting a study on experience of faculty and postgraduates on informed consent process from 2 tertiary medical teaching institutions in South India. To give a brief background, informed consent process we know is an integral part of biomedical research to ensure participant protection. There are several studies which have assessed the quality of the consent process from the viewpoint of the participants, and they have highlighted many challenges. However, we find very few studies which have explored the researchers' perspectives in consent process. So the objective of our study was to explore the experiences, challenges, knowledge, and sources of learning of informed consent process in biomedical research among the postgraduates and faculty of 2 tertiary care medical teaching institutions in South India. We conducted a mixed method study across the 2 colleges of 2 different universities. Following the approvals of the institutional ethics committees and permissions from the managements of both the institutions, we approached the participants. We called it institution A and B. We approached 68 postgraduates and 68 faculty in each institution, out of which 55 postgraduates and 65 faculty volunteered for the study. The study had 2 parts. Following an online written informed consent, we administered a validated online semi-structured questionnaire which explored several aspects of consent process. There were questions which were knowledge-based, which explored the purpose of consent, risks, anonymity in the consenting, elaboration of the methodology in the layman's language, waiver of consent, consent from the vulnerable population, and so forth. There were questions on their experiences regarding the formal training that they have had, different types of consent process that they have taken, and consent during COVID-19. Questions on challenges that they would have faced, like issues with literacy, time constraints, language barriers, refusals, and so on. At the end of it, the participants were given an option to volunteer for the focus group discussion, which was the next part of our study. We used a validated focus group discussion guide and we conducted FGDs until data saturation. There were 4 FGDs that were conducted across the 2 institutions. The FGD guide had questions which intended to capture an in-depth understanding of the various aspects of the consent process, which was a further exploration on the data that was captured through semi-structured questionnaire. The responses of the questionnaire were analyzed and descriptive statistics were presented. Quantitative data was presented as mean and ST. Qualitative data was presented as descriptions. The FGDs were audio recorded, transcribed, and analyzed using thematic analysis, and data was presented as themes and sub-themes. This is the demographics of the population, the participants who responded to the semi-structured questionnaire. You can see that there were postgraduates and faculty from across different years of the MBBS, and there were non-medicals who were PhD and research fellows. And among the postgraduates, there were students from across the 3 years. Among the faculty, there were faculty from across the different cadres. This is the participant profile of the focus group discussion. There were 19 postgraduates and 19 faculty who had volunteered for the focus group discussions. Just a glimpse of the semi-structured questionnaire responses. The responses to the questions on knowledge and training on consent process. The median percentage of correct responses on knowledge-based questions was 68% among postgraduates, while 91% among the faculty. We found that more than 90% of both PGs and faculty responded correctly to the questions regarding details of, say, purpose of consenting, the risk categorization, and anonymity that was involved in consenting. While less than 60% of them responded correctly to the questions pertaining on the elaboration of the methodology in layman's language, the questions related to waiver of consent and vulnerable population. Significantly greater number of faculty were aware about providing contact details in the participant information sheet and regarding the details of consent from the vulnerable population. 71% of postgraduates and 91% of faculty had attended some sort of training sessions in research methodology, which taught them about consent forms and consent process. This is a glimpse of responses to questions on experiences on consent process. Faculty and postgraduates had some experience on different types of consenting. Also, significantly greater number of faculty had obtained informed consent during the pandemic for research purposes. For the open-ended questions that followed these questions, they did express the challenges that they had experienced. These challenges were further explored during the focus group discussion. A glimpse of the responses to questions on challenges in consenting. Both faculty and postgraduate did face the issues of literacy, time constraints, language barriers, refusals, and they did find their own solutions to navigate through these. And these solutions, which were captured through the open-ended questions, were again further explored during the focus group discussions. This was a rich data that we got through the analysis of the focus group discussion. There were several themes and sub-themes that emerged through it. I will try to give a glimpse of each of it and try to convey what each of it brought out. 3 major themes arose: challenges in safeguarding participants' autonomy, the researchers' concerns, and some of the instrumental issues in consent process. There were several sub-themes which emerged under each of the theme, which I will be touching upon in the next few slides. Each of my slides will have the sub-theme highlighted, where I would be summarizing what the sub-theme brought out in black font, and in blue font I would be putting up the inferences that we inferred from it, and in italics I would be putting up the quotes which represent these. The value of trust. The researchers recognized that trust building was the foundation of consent process, yet They faced several challenges in gaining trust when there was stigma associated with research topics, influences of peers, fear of breach of confidentiality or anonymity by the participants. There was a clear expression that sometimes excessive trust downplayed the consent process. The vulnerability. Consent process was more challenging in subjects involving vulnerable groups, and there was a clear message that social and financial vulnerability compromised at times on the autonomy of the participants. Literacy, what we refer to as the level of education in this context, researchers perceived that it was easier to obtain consent from illiterates than literates. But another concept arose that the health illiteracy of participants, irrespective of their level of education, required the consent process to be in simple, understandable language, irrespective of the level of education. The comprehension and language barrier was yet another huge challenge in safeguarding the autonomy, and that further depended on several factors like age, literacy, local dialect, etc. But there was a message that a translator's assistance was most often facilitatory to overcome this language barrier. The researchers also spoke about the power dynamics, which was a challenge in safeguarding participants' autonomy. The dual role of clinician cum researcher in a clinical setting, or community leaders, local health workers, school teachers in community setting, did influence the consent process. So the issue of power dynamics between a treating doctor researcher and the patients sort of raised a concern during discussion whether the treating physician is really ideal to administer consenting. Researchers clearly recognized that the participants' safety was the main focus, and they really tried to strive towards it during the consent process. Fear of breach of privacy often deterred the consent process, especially in this cultural setting. What clearly emerged was that participants preferred to involve their spouse or the family members during decision making while consenting. The participants' readiness to provide consent depended a lot on the researchers' transparency to provide all study details. While some of the researchers felt that they did provide all the study details from A to Z, as you can read in the quote that I have put, but few of the researchers did express that holding back certain information was acceptable as long as it did not harm the study participants. This was the first theme. The second major theme were researchers' concerns, which included dilemma of detailing and researchers' safety and liability. The dilemma of detailing was influenced by several factors which emerged as sub-themes. Fear of refusal was one of the most prominent one. While there was a fear of refusal during consenting, the researchers felt that the refusal perceived was a feature of an unbiased, transparent, and well-informed and detailed consent process. The dilemma of detailing was greater in studies involving greater risks due to fear of refusal, yet researchers ensured that they provided all the study information. But at times, they felt that too much detailing in studies which involved minimal risk was at times detrimental to the consent process itself. Lack of time, infrastructure facilities, finances, logistic difficulties in approaching the participants were all often looked at as roadblocks to detailing in the consent process. This was an interesting finding. While some researchers were confident and trained their team in the process, majority were unsure of the right way of the consent process itself. So there was a clear message or inference that came out through this study that lack of confidence of researchers in consent process warrants the need of training and certification, or probably some in-study audits, particularly for high-risk studies or involving vulnerable population. Several factors influence the researchers, like the tendency to include their colleagues as healthy volunteers, recruiting literate subjects to finish consenting and to finish the study, or tendency to elaborate the role of incentives. So all these brought in an element of bias during consent process. That was their experience. So the researchers' concerns, the next sub-theme was researchers' safety and liability. Researchers at times did feel endangered in a community setting while performing community studies by several factors, like rumors spread by few locals, which created distrust in the minds of potential study participants. Most researchers took the help of the local leaders to bridge this gap and help in trust building. So that's a very powerful quote from one of our researchers. Researchers feared that their liability was also at stake at times when caught with the moral and the legal dilemma, like participants when they encountered participants with teenage pregnancies during the research study. So how do they handle such things? What about the confidentiality and anonymity and so on? The third major theme that emerged were instrumental issues, which included the types of informed consent, the sources of learning, and the special situation of consenting during COVID-19. Researchers highlighted that the participants' apprehension regarding the affixing the signature on the consent form is a major concern as far as written consent is concerned. Skepticism and legality issues crept in their minds while they were asked to sign in the consent form. Few clinicians felt that AV consenting was best as it addressed the literacy barrier and was a visual proof which offered the participants and the researcher good protection. There were experiences of telephonic and online consent also, but it had advantages like it saved time and travel, but it had challenges of lack of face-to-face interaction and issues with connectivity. The two major sources of learning for our researchers that emerged through their discussion were regulatory bodies and training and modeling. Few of them expressed that the orientation program conducted by the ethics committees and the comments that they receive on the consent form when the proposals were sent for review provided good insights and helped them revise the consent form. But few felt that the consent process could also be simpler and need not have so many regulatory guidelines in very low-risk studies. Postgraduates and junior faculty expressed that their guides, seniors, peers, and ethics committees do provide inputs in revising the consent forms. But the major thing that emerged through this discussion was that most of them felt that there was a serious lack of hands-on training in administering the consent process itself. But one of the postgraduates also expressed that these things need not be formally trained and one could learn it through workplace-based experience. Researchers expressed that adapting to pandemic situation and continuing research was a big leap in learning during the COVID-19 pandemic. Logistic issues like using masks, PPEs, social distancing during COVID-19 hospital setting, fear of pandemic, discharge against medical advice of patients were all challenges that they faced during research in COVID-19 situation. But the learning was increased use of technology and online consenting, which was good. So to conclude, most researchers were sensitive to the spirit of consent process. They faced several ethical concerns related to participants and themselves, training and logistic limitations, which made it difficult to materialize the ideal way of consenting into actual practice. Special situations like pandemic posed challenges, but it led to new learnings in consent process. The role of guides, ethics committees, and guidelines from regulatory bodies governing the consent process was recognized by the researchers. But there was a clear message that there was a need of hands-on practical training which would provide exposure to real challenges and better preparedness to conduct consent process. This was identified through the study. These are my references, and we acknowledge Rajiv Gandhi University of Health Sciences for funding this study, and I thank the postgraduates and faculties of the two colleges for being my volunteers. Thank you.
Thank you, Dr. Savitha. That was a well carried out study, and you have brought out exhaustive list of various challenges faced by postgraduates and faculty in conducting research. So now it is open to the floor for any questions from anyone.
I am also the member secretary of our ethics committee. The most common complaint, or you can say what the students, the postgraduate students and faculty members say about informed consent process is that they don't have time to complete the process. What was your view? Any points came on that aspect?
Yes, yes. So as I put up, there were questions on the challenge of issue of time constraints, both in semi-structured question, and we explored it deeper in focus group discussion. What came out was both from the postgraduate as well as busy clinicians. They mentioned that time was always a factor in the busy OPD. They recognize their participants, they have to take consent, but they don't have time or patience, both from the doctor as well as the patient side. But how they tried to tackle this was that they took their contact details. As long as they have agreed to be a part of the study, they did take time out of that, and they contacted them, they visited them, and they took the participants into their study. This was a concern mainly for the patients who were recruited in the OPD basis. If it was an IP patient, still it was still, yeah. So many of them said, and of course many of them said that they lost out on many of the participants only because of the time constraints. They were willing to be a part of it, but in some of the settings, they were not able to come back. That would cost them again. So in such situations, they did lose out on a lot of participants. If there was a follow-up, it was much easier to catch them again.
More a comment. I felt that during COVID, there was much more of phone consent being taken. And I think this proved to be very useful because, like you said, in a busy OPD, what we ended up teaching our students, postgraduate students, to do was to take the patient's contact information and request whether we could speak to them later. And then later on, in a more relaxed fashion, the phone consent could be taken. And I think if we didn't have to go through the COVID pandemic, we may not have utilized this route of taking informed consent as much. The second is a comment that we don't allow undergraduate students, they want to participate in research, but they may witness informed consent being taken, but they don't get to actually do it themselves. So my question would be, how do we prepare postgraduates to take an informed consent? From my experience, I sort of help them prepare a script. You know, this is exactly how you go through it step by step. And you, obviously then after a few times they get very comfortable. But is there some structured teaching on how to do informed consent for postgraduate students?
Maybe each of us at the level of the institution or ethics committee have to develop this structure as to how to teach them to take the consent. In my own experience, when I have guided one of the undergraduate to do her first study, the student was by nature very much an introvert and inhibited kind of person who was not very comfortable doing this task. So actually one of my co-investigators is also here who was actually helping me with the whole study. So we actually made a script. We made the student learn it. We made her administer on us first, and then we revised it. So we had sort of a role play, and then there was second time when she actually did it on the first participant, second participant when we monitored, and then we allowed her to do it independently. Maybe, of course, this came through my study also, where some of the clinical departments, busy clinical departments in one of the institutions, they have this structured program where they make the PGs do a role play in their institution in front of the department as a department presentation, and then they allow them to carry on the study. That came in through from one of the participants.
Hi, sorry I came late. This is the way we queer time, we queer people, we have our own concept of everything, right from how I always enter this campus. I've been coming to this campus for I think 5-6 years now, and have many dear friends and colleagues, HODs who say, don't call us doctor, call us by name, because you're many times helping us unlearn and relearn. So, I am not trying to teach you people anything, but I am just requesting that when you know, many of us are intersectionally marginalized queer people with all my privileges. If I talk to you about invisible disabilities and all, you will know that some of us actually seem privileged, but not are privileged. There are some of us who are much worse situations. But I hope that whoever is considering consent, please make it oral consent. Please remember that, you know, people may not be literate even in their own native tongues, okay? And you cannot reduce the content of a consent form by saying, oh, I will translate for them, I will read out to them or something like that, okay? Just because they are not literate, you know, please do not, you know, change your consent, this thing that you will oversimplify for them to the extent that they don't know for what they are giving consent. And sometimes they hesitate to give consent and then they are declared non-cooperative, okay? This has happened with many people who approach us. You know, we want to research trans people. I'm also gender fluid, so which comes under the trans umbrella. And I said, what is your understanding of trans? And they would say, oh, people I have seen at Signals. I said, they're one kind of trans, you know. And don't say we are researching trans people. We are researching with trans people, okay. So I will talk more when we present, but this is just a request, okay, as a person of a community who, you know, often becomes a subject or object of research, but is never informed, never seen as a co-contributor, never seen as a person who has their own lived experience and knowledge and can teach people what they think they already know. Okay, thank you.
Thank you for those valuable inputs, ma'am.
Any comment from your side? Okay, fine. Anybody else? No?
We'll keep this in mind when we get such proposals in our ethics committee. Thank you for that input.
Well, before you go, I think I have a few questions. I just kept them reserved. I thought that people will ask, but they didn't. I'm really impressed by your study, and it's a very good study. And I hope you're presenting it for the first time in a conference. So I hope you will be able to revise it and get it published somewhere. I have a few questions. One is that I would have liked to see what are the limitations of this study? Because you have never said anywhere about limitation. Because you are studying postgraduates and the faculty. And that also in the informed consent. For me, the consent focus is the person who is participating, not the person who is researching, you see. The person researching can have different viewpoints, but what actually is happening in the minds of the person who is participating or giving consent is very important. So perhaps if you can mention it in your limitation, that part, that this is the viewpoints of the medical people and not the viewpoint of the people on whom research is carried out. The second thing that when you were talking about the findings, you know, you said that illiterate gave consent more easily than the literates, which is not, I'm not surprised at all. I ask any doctor here and they say that literates really irritate us, you know. They come with Google knowledge and they ask us questions. And that is, I think, fundamentally we don't like being questioned. And that's how they say that Google knowledge is not good, but all of us use Google and have Google knowledge. You know, say even, you know, best of the doctors, you know, and most of our databases are ultimately searched through the Google. So we don't mind our own thing, but we do. And so this whole issue of literacy, if you have more information in your conversation with then just try to deep into it and see what are the nuances coming, because they're making a strong statement is not sufficient. What are the nuances that how and why they are doing it? Are they tolerant to their patients if they ask? Or are they intolerant only to the participants and then patients' questions they are answering properly? So the third was in the privacy section. You said that they wanted to take opinion of other members of the family. Now that requires qualification, right? A man normally will not take opinion of the other member of the faculty. Wife will, daughter will, right? So the issue of dependency. I mean, if I'm an old man, yes, if I had to do something, I have to go and tell my daughter, because she is the now, big enough to take care of us. So this dependency relationship in the house and family and is very, very important, because you just can't dismiss it by just saying that it is a privacy concern. But it is related to the power relationship. That is what you have actually stated earlier, but you have not applied, yes, connected.
There was social vulnerability there was financial vulnerability,
absolutely,
dependency, there was power dynamics.
Yeah.
They're all interwoven.
So who are the people who are saying that we'll consult, and who are the people who don't consult? That becomes, even in the qualitative research, asking, that becomes very, very important. Yeah, it's rest of the things I have more or less. And one thing that I wanted to ask, which is very general, I didn't get any information about how voluntarily they give consent. The giving informed consent is fine. She made issue about how they understand. That was it understood consent or it was just informed, that one-way information. I tell you all these things. But that is fine. What I'm worried about is how voluntary it was, because you said that there were some of the researchers were also physicians treating them. And if you are my physician, I have almost no way of having autonomy, to be independent of you. So the independence is the first. We say voluntary informed consent. We normally keep talking about informed consent, but voluntary, we just discard. So what was the voluntariness this faculty members and the postgraduate students encountered, that how voluntary they were? Or, yeah. I mean, when you ask them question, or you did in-depth interview or the FGD, if you have any information, try to bring out, because a lot of, I think in one session in the morning, they were talking about systematic, system-based coercion. I have no money, and you are my main provider, and you're not going to charge it. And so how can I say not to participate? I have carcinoma. If I get standard care, it costs me lakh rupees a month and don't have money. So I said, I joined the clinical trial, So there is what we call push factor, where there is no voluntariness. It is just because I have no choice. And in India, it is very, very high. Because most of the vulnerable people you recruit, they may not be coming voluntarily. You may say altruism is there, but where is the real altruism? That I still haven't found so much there. So if you can just look up those issues, it will be helpful.
Thank you.
Thank you, sir. You brought out a lot of points which she can develop on. It was an exhaustive study. Very good.
Thank you.
So now I call upon Pooja Harish from Ennapoya University. She's adjunct faculty for Center of Ethics there, and she's an orthodontist. Her study is on assessment of knowledge, attitude, and practice on therapeutic misconception in biomedical research among dental postgraduate students. Dr. Pooja.
Good afternoon, everyone. Can I get a good afternoon back? Yes. I'm Dr. Pooja. ನಾನು ಇಂದಿನ ಅಂತಾರಾಷ್ಟ್ರೀಯ ನೀತಿಶಾಸ್ತ್ರ ಶಿಕ್ಷಣ ಸಮ್ಮೇಳನದಲ್ಲಿ ನನ್ನ ಸಂಶೋಧನೆಯನ್ನು ಪ್ರಸ್ತುತಿಸುತ್ತಿದ್ದೇನೆ. How many of you can translate what I just said in English? Anybody in this room who is from Karnataka? Yes, I can. Otherwise, I wouldn't dare say that here. So, anybody at least understood what was it? Yes?
Today I'm going to present my study in this International Ethics Education Conference.
Yes.
Yeah.
So when I said it so fast and sudden at the first time, even ma'am couldn't understand what I said. But still her Kannada is too good, so she understood. What I'm trying to tell is my topic is on therapeutic misconception. And I wanted to tell you, if I don't speak in English, none of you will understand what I'm presenting. And in an English which is verbal, which we speak day-to-day life, not even the pure form of English. So when we are doing a research and we are using some technical terms like jargons to explain the participant what we are going to do on them, they will definitely not understand. For example, me being a dentist, I'll give a small instance. Imagine all of you, you come to me as a patient, and you have a toothache. And I'll give you your diagnosis. Please raise your hands, except for the dentist here. Please raise your hands if you understand what your condition is, okay? So you have come to me with a tooth pain, and I'm telling you, okay, the IOPA shows that you have a deep dental caries, which is involving the pulp, and there is a periapical abscess also. So a restoration cannot be done for this. We have to do a root canal treatment. Do you agree for the treatment? Did you understand what is the condition? Okay. Abscess. So I'll change my dialogue a little bit now. Okay, we took a small X-ray of your tooth, and I can see that there is a cavity, and your cavity has gone too deep. It is involving the pulp now, which is the nerve supply to your tooth, and there is an infection below the roots of your tooth inside the bone. So we cannot do a filling now, because it will increase the infection. We have to remove that pulp which is there inside and then do a restoration, fill the roots and do the restoration, then put a cap. So do you now agree for the treatment? Yes? So I didn't omit any information that I said in the technical terms, but I explained everything in a language which you could understand. I did not dilute the information also. So this is how informed participant information sheet should be, so that the patient who comes to you should understand that they're not getting a routine treatment, but it is a research protocol which is being done on them. And why this is important, especially for researchers, is most of the research settings are done in a hospital which is attached to college. And patients, most of the time, they do not understand whether it is the routine treatment or a research protocol which is still under testing, which is being imposed on them. So I wanted to study, this is one of the image which shows, this is the researcher this side, he wants to tell 1, 2, 3, 4 points to the participant, but they understand something else because it is not in their language. So therapeutic misconception is the failure of research subjects to appreciate the distinction between imperatives of clinical research and of ordinary treatment. And why I conducted this study was, there are many studies, if you go through the literature, on therapeutic misconception, which they have elicited among the participants. But I feel it should come from the researcher first. The researcher must understand what it is and how to avoid it. And then when we assess what the participant is going through, we can bridge the gap and develop better communication methods to overcome this hurdle. So my aim was to assess the extent of knowledge, attitude, and practice about therapeutic misconception in biomedical research among dental postgraduate students. I chose dental postgraduate students because every PG student will become a researcher for the first time during their PG course. If they were too good, maybe in UG, but most of them first time as a PG. So we started from there. It was a cross-sectional study. We developed a 26-item questionnaire. In that, I had 4 questions on knowledge section on the informed consent and 7 on therapeutic misconception. Then, instead of giving questions to them or statements, I formulated a small story, which by giving a dentist name like Dr. Kulkul, and the patient was Mrs. Brackety. And the scenario was that Mrs. Brackety is a long-term patient of Dr. Kulkul in a private clinic, but he is also a faculty in a dental college. And he will be doing a study with his postgraduate on a mouthwash. Mouthwash is the least invasive, so we took it. Just to know from the least invasive level how their attitude and practice towards it is. So the scenario goes like this. The patient, Miss Brackety, she comes to his clinic and Dr. Kulkul gives her the mouthwash. he will not tell her whether it is under research or a new mouthwash, what it is. He just gives it as a routine treatment and asks her, you use all of this and then come back, I will see how your oral hygiene is being maintained. Then we formulated questions on this scenario to elicit how their attitude and practice is towards avoiding therapeutic misconception. So to avoid the anonymity, we made few of the agreement questions and few statements as disagreement so that we can elicit the response better. Source of data, postgraduate students of Yanapay Dental College. Inclusion was the students from dental specialties who have started with their thesis or a research project, and exclusion was students from other colleges and who have not started any research. And after the ethical clearance, simple random technique was used. Sample size was calculated by referring an article, and we arrived at the sample size of 90 participants with 95% confidence interval. The questionnaire, I circulated it through Google Forms because it is the easiest way to do it. And the informed consent was mentioned. The PIS link was given in the Google form for them to go and read the document. And informed consent was considered applied if they click agree or move next to the next section of the form. So after all this study, we got the results as participants had fair knowledge on informed consent procedure, but their knowledge on therapeutic misconception was poor. And they had a fair attitude towards avoiding the therapeutic misconception, with just 52% giving the desirable response. And surprisingly, they had a good practice towards avoiding therapeutic misconception, with 64% giving the desired response. So coming to the discussion, I have chosen only those questions which are of importance for discussion here. There are many other questions. So first one was when a regular participant agrees, patient agrees to participate in a study, based on the trust, will the consent be considered? The options were completely autonomous, possibly influenced, both or none. And 51% they said it is completely autonomous, which shows that they don't have any knowledge on what is therapeutic misconception. And 25% said both. That makes a big chunk of the participants who don't know what is therapeutic misconception. Then we asked, participant information sheet educates the participants that drug, implant, or procedure provided is. The options were a research protocol, not regular clinical care, both, none of the above. And 61% said it is both. So they knew it is not a regular care, but it is a research protocol, but they didn't know that the participant should know about this. That is the two conflicting responses which we got in the knowledge section. Then coming to the attitude. With poor knowledge, I felt like their attitude also will not be that great towards avoiding therapeutic misconception. But surprisingly, few answers were desirable, maybe because it was a research and we were asking questions. They must have thought what could be the ideal answer. We tried to avoid it by giving a scenario where we don't put them under a situation where we are judging their responses. They were supposed to judge Dr. Kulkul, not themselves. Still, little biased responses were there. And when the first question here, it is about, was the doctor right in not elaborating the patient, his trustworthy patient, that the mouthwash is still under study? And most of them disagreed with the question. So they felt like, yes, the participant should have known that the mouthwash is still under research. But the next question, where we asked if the patient informed consent while taking the informed consent, should the patient have been made aware of other alternative treatments? Because it's very important in avoiding therapeutic misconception, or while during an informed consent procedure, we have to tell them what other options are available. We should not just tell them what is our research protocol. So when we asked, most of them agreed with it. Yes, they should be made aware of other options. And in order to ensure good compliance, should the doctor not inquire, not tell her about the other better existing options? And most of them disagreed with it, which shows that their attitude towards avoiding therapeutic misconception is fair but not good enough. Then coming to practice, we asked one question where we said, Dr. Kulkul must have explained Ms. Brackety that use of mouthwash is not a part of a regular treatment. And most of them agreed with it, which shows that they have a good practice towards avoiding therapeutic misconception. But when we asked, Ms. Brackety signed the informed consent, and there is no need for the doctor to find out during the study if she is aware that the mouthwash is still under research, then they disagreed, which shows that we have to reinforce and get a reassurance from the participant that even during the research, they still know that they are under the research protocol and not a regular treatment. So therapeutic misconception, it is avoided not only in the stage of recruiting the participants, but throughout the research, we should make sure that they are not under this assumption that it is a routine treatment. So my conclusion is knowledge of the participants on informed consent procedure is good, but poor on therapeutic misconception. Attitude was fair towards avoiding it, and it requires reinforcement. But despite the lack of knowledge and fair attitude, they had a good practice towards therapeutic misconception. Still, we cannot rest because they should know why they are practicing these. With this, I end my presentation. I thank all the chairs, delegates, and the organizing committee for giving me an opportunity here. Thank you.
Thank you, Dr. Pooja, for that very well-conducted study. It was very informative.
Thank you.
Now, questions open to the audience. Anyone has any questions regarding the study?
In the introduction, you have used research subject.
Oh, participants.
Okay. Because you are CFE. That's why I'm telling you.
I can be assured that nobody, sir, is not sleeping now after this.
No. And it is very interested, but actually, see that in MD, first year, second year, third year, in which year they will go for the research?
After 6 months of their enrollment.
Enrollment. Means after 1 year, they know they have to conduct a research. Is it like?
After 6 months.
Because in first 6 months, they know they have to conduct some research. And in second year, they will well aware about that. It would be very good if you will correlate their educational year with this therapeutic misconception. Because what normally we understood, see, when we join something, our totally focus towards treatment. We are here for the MDS degree, not for the research. And the scenario which was given, because we are biased from our mind, because when we read some case scenario, we didn't able to identify. So when you accumulate all the findings, so the picture is changed. If you will see in your result first slide, the Likert scale is something different, whereas in second question it is opposite.
Yes.
Understand? Why? Because it is a cumulative number. You are taking total. It will be suggested. It is your study. In future, you will just see. You have that data. You will just go in the Excel and see the correlation. It may be possible that second year or third year students having a best knowledge about therapeutic misconception rather than the first year students. This is my...
this was an initial baseline study which we started first to know how much, what is the starting point for us. And then we wanted to develop more elaborate studies. But yes, I did collect the information on which year MDS they were, but I have not correlated that with the results. So I can, maybe I will include it in the publication later. Thank you.
Thank you for the presentation. I just had one question. So when you ended with that there's a need for reinforcement, so could you just elaborate on that? It wasn't clear to me much.
Yes, their practice is very good in avoiding therapeutic misconception because they don't know what is therapeutic misconception. They don't know how to avoid it, what practices they can adopt, or anything. Like their attitude part is fair enough, but practice is good, which is not a good sign because on time, with time, it might get diluted. The seniors might tell, no, it is okay, you do it. Because even the seniors doesn't know why they have to do it. It is a trend which we follow, which we see in most of the batches. When we see a postgraduate student where the department becomes too strict, that batch will have a very good quality. Over time, the staffs, they feel like, okay, now we have corrected one batch, they will follow. Over time, it will get diluted. So when one batch knows what is therapeutic misconception and they transmit that knowledge to the next batches, their practice will be based on the knowledge, not just because somebody is doing it. So if they don't know what it is, and they are just telling, no, you just have to do it, otherwise they will tell you it is wrong, then the practice might get diluted over time. So we have to reinforce their knowledge first. Reinforcement, I meant in the terms of knowledge, so that they know a scientific basis of why they are doing it.
Yeah, I also misunderstood that this has become more clear now.
Yes.
You want the participant to have reinforcement and
Yes.
not the subjects of the study. Yeah.
Participants reinforce their knowledge on therapeutic misconception.
Okay, that is clear. Any other questions from anyone? Sir, yeah.
A few questions, I think. So
Yes,
otherwise, it will be completely. No, it's a good study, and you have worked very hard. But the CAP studies are always problem. They contain a lot of biases of the researcher. So how you define knowledge, how you define attitude, how you define practice, that will decide what you find out at the end. Nowadays, unless you have come out with something radically different, CAP studies are not looked at by the journals for worth publishing. Keep that in mind because you will have to go to journals to publish it. I have three questions. I think both of you use the concept of trust, and because this is a study of the providers, and providers keep talking about trust. Why do they keep talking about trust? And do patients also talk about trust? And my thing is, if patients trust you as a researcher, then don't you think that therapeutic misconception is inevitable? If I am a patient who said that I will trust but verify, I will find out whether you are right and what you want to do is good enough, then that means I question you. From your motivation to the kind of research that you are carrying out. It's like, the trust has become a huge thing with vaccine hesitancy and all. Everybody keeps talking about people losing trust in vaccine and all. But why shouldn't they lose trust? If your science is bad, and if you, I think something is happening. and if you don't take care of people who, suffer due to vaccination, then there is a problem. Anyway, so there's a trust, you need to unpack it properly. Otherwise, if they trust, they don't question. And if you are also a researcher as well as a clinician, then they're trusting you, that they are also trusting your research. And they will always have a misconception that you are doing the best for them, right? And there is another thing that you, I think, reference. There's a paper which says, which is titled is clinical equipoise. I was quite surprised that you didn't connect therapeutic misconception with clinical equipoise, because one of the reasons how the researchers have a misconception. This is researchers' misconception, is that the new treatment that they are offering is the best treatment. And I have seen a lot of researchers telling patients that this is a clinical trial, but you know, this one new one that so-and-so company has brought out is excellent as compared to the current one. Now, if you from the beginning, you believe that this is better, then why do you do experimental research at all? Isn't it? There has to be uncertainty, whether it is better or worse than the currently available. Right? But if you are convinced that it is better, then of course you are going to, by your own action and talk, you are creating misconception in them. So there is a lot of therapeutic misconception which is caused by researchers themselves in the patients, rather than they being a problem. I think we are a major problem, and that is how we have to. Yeah, and the last thing is about, you said that misconception only in ICEE, informed consent process. But in clinical trial is a prospective trials. And that goes on for 6 months, 1 year, 2 years, 3 years. And what you do is that you keep reinforcing, otherwise they drop out. If they withdraw, then your sample size goes down. And if you are not taken care to have oversampling, then you lose. And so you are always, having that nightmare that my patients will stop, being on the clinical trial. So this is that reinforcement comes from the researchers again. You must have seen Miss Evers boys on Tuskegee trial. You will find that for 40 years they kept reinforcing on them the whole therapeutic misconception they were under.
Yeah. Good study. One quick comment on your case scenario. If you said this patient was a long-term patient of this doctor, dentist, and that itself can lead to trust and all the problems of therapeutic misconception. So maybe you can tweak that case scenario a bit when you do it next time. Okay, good study. Give her a hand of applause. Now I call upon Ritash for her study on Okay.
I interject happily.
Okay. Redefining research ethics, inclusion and intersectionality in LGBTQIAP plus studies.
Right. So I'll just introduce myself again very, very quickly. My name is Deeksha. I'm joined by my co-founder from Run Foundation, Ritash. And today we do ethical community-rooted research with the LGBTQIAP plus people in India. As queer and neurodivergent individuals ourselves, our work is not just shaped by data theory, but also by lived experience, essentially by the realities of being both visible and invisible in different kinds of spaces. What we do at RUNG is, for us, stands as a testament to the resilience and diversity of India's LGBTQIAP plus communities. And we want to essentially build on that and talk not just from a perspective of of a theoretical perspective, but also lived realities. So as all of you know, it's been a long time since Section 377 of IPC was read down. It was read down in 2018. But for a lot of LGBTQIAP plus folks, especially those from marginalized castes, rural areas, or religious minorities, daily life hasn't changed that much. Post the reading down of 377, in the next year, India accounted for nearly half of all documented human rights violations against queer people in South Asia alone. Even within the queer movement, certain voices, like those of lesbians, gay, bisexual people, transmasculine people, or queer people with disabilities, are still pushed to the margins. This silence isn't accidental, it's structural. It shapes who gets researched, who gets funded, and whose pain is seen as valid. So for our objectives, we are focusing on, we want to challenge how queer research is done. Did you know that most of of the researches that happen in India focuses on gay men or MSM community. Lesbian and bisexual women appear only in just about 4% of studies. Transmasculine people, only 2%. We believe that research should be participatory, intersectional, and healing, not extractive. It should create a space for stories that don't usually get told and offer something back to the people whose life we are documenting. So we want to critically examine the dominant research practices and propose inclusive, participatory, as well as ethical approaches. Coming to the ethical concerns and the background. Essentially, unethical research is not just a bad practice, it's harmful. We've seen projects where caste and class are completely ignored, where consent forms are written in English and explained really poorly. In my own experience, I've had people from the Hijra community tell me that other people from research backgrounds come and study us like they were case files, but nobody follows up after their research is done. There's nobody who comes back to them to even tell them about the results of the study. Even the institutional review boards in institutions rarely include queer or trans voices. And often, research becomes another site of trauma rather than a tool for justice. So, essentially, this is a conceptual and a reflective presentation based on our insights. In the last couple of years, we have spoken to a lot of queer individuals through the Ravi platform and our own works, from small towns to metros and even globally, listening, collaborating, and co-creating. We also have read up on the studies that have happened and been completely immersed, even during COVID, with community members who shared how losing certain ways of expressing themselves, certain spaces that were safe for them before, how that didn't just hurt their income, it shook their sense of self. These stories, along the time that we have been researching, has taught us that behind every statistic is a human being searching for belonging, joy, and respect. They also remind us that it's not just a data point that we're looking at when we're looking at a research, it's a person behind that data point as well. So the key frameworks that we have actually covered here are the 4 frameworks that have guided our work. The first being Intersectionality by Kimberly Crenshaw, that helps us see how identities like caste, class, gender, and religion overlap. For example, we tend to homogenize the LGBTQIAP plus population. However, even within those spaces, a person coming from a Dalit or an Adivasi background, or a person coming in with disabilities may face exclusions within those queer spaces themselves. Additionally, we have focused on CBPR, which is community-based participatory research, which essentially means that we're doing research with, not on people. However, we still see that a lot of Indian studies for the community are not done by community members themselves. They do not have queer community members in the design or the implementation or the IRB boards. And we are advocating to change that. The next is decolonizing methodologies, essentially reminding us that queer knowledge doesn't only live in academic journals. It lives in local languages, in rituals, in religious minorities, stories that are often sidelined in elite English-speaking spaces. It's not just an academic exercise. The fourth being focusing on the ethics of care. Discrimination in healthcare remains pervasive, with queer community patients reporting both explicit and implicit biases in public and private spaces, specifically hospitals. So there's also studies that call for urgent reforms in medical education, because we're still living in a very binary world when we come to medical setup. And we want to advocate for research and practices that ensure dignity and equity for all LGBTQIAP+ patients. Ultimately, our goal is simple: to make research a tool for solidarity and not for surveillance. Beyond this, my friend Ritash would take this forward. Thank you.
Hi, thank you, Deeksha. I'm not sure you can hear me, but this feels like also I am not technologically disabled or challenged, because I supposedly come to the computer science experience degree and also, but this happens to me anyway. So with that, I will take over, and this kind of neatly connects with what I had said during Dr. Professor Savitha's presentation. And this is just not about consent, it's start-set consent. When we talk about homogenization, okay, and I know there are one or two openly queer people here, sitting here, and also one of my fellow co-founders of Run Foundation is here, Oshmita, but, and we've all grown up, got our degrees. Some of us in gender studies, we're still talking only in the binary. After claiming to be an inclusive environment, in this day and age, I'm not even talking about the 90s when I got my engineering degree, okay? So, and which is why sometimes we I think have to forget what we've learned, forget about, requesting others to unlearn and relearn. So now, back to what we're talking about, homogenization. You can continue to just scroll the slides, we're just querying the space. And by the way, this is Pride Month, but we think that Pride Month should be all through the year, okay, and should be Intersectional Pride Month. But anyway, so they'll be like, a potential PhD candidate came to me for a couple of years. I'm not mentioning the institute name, but I'll be happy if you can guess it. It is from what was claimed as Asia's largest mental and neurosciences health institute, which is headquartered in Bangalore, and it's over 50 years old, you can very well guess. Okay, so she came to me saying that her professor contacted me because that person's retired HOD, he was an advisor to one of our organizations, okay, a community organization, yeah. And they were like, I want to research transgenders. I said, you want to research with trans persons, right? And she said, no transgenders. I said, trans persons, please. First stop dehumanizing through language. This is not about grammar. This is about people. Okay. So how many trans persons have you met? Oh, my professor has seen some people at a traffic signal. And you want to research? Okay. I have some questions for you. But no, my research question, I want to have a detailed conversation with you, and I sent her a list of questions so that she would be prepared for that, okay. It's a different thing that she could not convince me with even a couple of answers, and her professor kept tagging, you are not. I said, I'm not gatekeeping. I will be betraying my community if I introduce you all to even one person if this is the attitude, because she didn't stop at that, the professor did not stop at that. We will be designing suicide prevention programs, okay, for trans persons. Okay, how many trans persons will be in your program design committee? No, experts. I said, experts means, obviously you mean our community leaders. I knew very well what she was getting at, but I deliberately kept pushing. No, experts. Who experts? How many years have they worked with? Oh, you're talking about mental health professionals. Okay, fine. How many years have they worked with trans people? No, we are still designing. But yeah, but you are designing a program of suicide prevention for trans persons. Okay. But you're not doing with trans. That itself is terrible. Plus you're saying expert, and none of you all have even met a trans person for one time in your life. How is that not just unethical? How is it even pragmatically possible, So why are you going on saying experts? But this is the kind of people who come to us. I want to research on trans persons, and I'm repeating, they can say this in Hindi, Kannada, or Bhojpuri, okay, they will keep saying, because then it is very clear what is their gender, what is their class, this thing, what is, So we have not just become objects of research and subjects of study, but also people who can be exoticized, at the same time pathologized. I am daring to say this with, people who are researchers, doctors and teachers here, okay? But I know some people, again, institutions like St. John's and IJME, which I know Dr. Ramanjasani here is one of the persons who's like on the editorial board or whatever, is still an exception. But why do we need these exceptions? Okay, why can't we be treated as other human beings? And I still, and Deeksha and Ashmita here are more privileged. They're at least able to come and talk. Just because someone can't talk, actually, I think the dentist, Dr. Pooja, right? I like one point which you made, we are presuming that everybody knows English. Everybody, we say in the legal, medical and journalist professions and all, it's good to know many languages because you want to connect with people, right? So then, why do you presume? Why does every researcher this thing? And this is not just medical research, which is why we were glad that this conference is about ethics and education, which we presume is about all, subjects of education. Okay, and this happens in sociology research. This happens in anthropology research. It's an exception that a queer trans person can even get a PhD because you're like, oh, but you have the Transgender Persons Act, Section 2, IPC Section 377 was read down and all that, What about the legal professions? There are 3 people, I have audio visually recorded live interviews with 2 of them. One is Shahira, who is an Andhra University MSc graduate, and one who is, so she's a practicing Muslim and a trans woman. One is Yashika, who is a Punjab University MA in Political Science and Human Rights. And these people have gone with transgender ID cards and look at what the world presumes to be trans women to be, in the sense they've had biological transition, and yet, they do not have gender inclusive accommodation, which is supposed to be guaranteed. So they've also joined as trans persons for their PG course, okay? And still, why don't you adjust in the women's, first of all, why should I adjust? Will the others adjust for me? Because there are people who will stop them from using washrooms. Yeah. So, see, this is not a study, this is about our lives. Okay, so please do not call it study. And if some of you think I'm being disrespectful or irreverent, so be it, okay? Because we've had enough of being, polite and nice in our demands. We think if the world wants to know about us, fine, but in the way we want it to be. And this is what we are requesting, not even requesting, suggesting, we are demanding that the world who wants to get a PhD or a research or publication at our expense, do it on our terms. Thank you. Yes, this might sound like a political speech, but now our existence is political. Okay, what is not political in this world, tell me? Yeah, thank you. Yes, I am an engineer, just once again, I am an engineer trained in the sciences, but I am a human being with emotions, and I like to show my emotions when it's required. And this is one place like that. Thank you so much.
Thank you, Ritash. Yeah. We got about a lot of aspects and the need for inclusivity, need for the ethics committee to take these things which concern you when we are reviewing studies, and to include your community when we are finally reviewing, and bring you in when we are discussing the studies in your community. Thank you. Any questions from the audience?
Just a comment and also a way to share the reflections. So we are researchers, academic folks sitting inside our ivory towers and scrambling for these research grants. And when we write up the grants, we have to openly accept that sometimes including words like trans people or people with disability is attractive for the funders, or the call for proposal is designed that way. And at the heart of hearts, we are not working for the beneficence for the people and not involving in the community participation during the research design phase. And we submit the proposal. Outcomes are decided and objectives, everything is decided. And then we go out to the community. Their needs are completely different from what is proposed. Some of the funders are open to change. They are accepting. But some of the funders are very rigid, as you know, And it really, we are also facing the dilemma and the moral distress when we are doing all this. And recently also Ritash and me, we discussed a proposal and we didn't take it forward because it is not for the beneficence of the population. If at all, sit and listen to them rather than doing some biochemical examination on them and understanding whether their biology is different from ours. By ours, I mean the heteronormative population.
Yeah.
So that is the kind of experience we have had, just wanted to share.
Thanks, Dr. Nancy, but also I think it is valid to say that the research that we are partnering on, which we've gone through with, is about, since again we want to fit it to a medical environment. Janvi, I would like to introduce you. She's an MD student here in community medicine, Professor Nancy's department. And so we are doing on relationships with amongst the queer community, but I also said let us bring a health aspect of it, okay? So I think it's good that at least they're making these steps, but it should not be an exception. That's all I am trying to request, and what Deeksha and Ashmita and all of us are requesting in any field of education or research.
Yeah.
Come on.
The research is funded by the Institutional Ethics Committee of St. George's.
Anybody who would like to speak something? Any other comment on this presentation? We still have time, more than 10 minutes, because one person didn't turn up. So there were 4 presentations. We are just doing 3. Anybody else? She has, I think, quite provocative presentation in a way, and
We're deliberate.
medicals should be responding. Don't they? No? Yeah, yes.
Thank you. I exist to provoke.
No, that's good.
I like the debate.
Yeah.
So thank you for your presentation. I just wanted to ask that in one of the slides it was mentioned that building context-specific ethics toolkit. So what's your vision for an ethics toolkit? Like what does it look like? Or what are some of the things that you should be there and must be there?
Okay, I will say that in caution for what you can have. Okay, fine. The thing is that, taking the liberty because of the technical challenges of Deeksha coming back in, and I think in a way thanks to Professor Deborah, because she pulled out, we used this time gap, universe has wished it for us, I think. Okay. Yeah, so an ethics toolkit, as I said, one point I'd already mentioned during the consent session, which I think is not just for the queer trans community, it can be applied to anybody who is, sort of not used to this thing, or where trust is a big thing. And I liked where Dr. Ramajasani said, why call them illiterate? Yeah, they may be literate in a different language, in a different body of knowledge, right? Many of us, especially in South Asian cultures, look to what our grandparents taught us and then realize that, turmeric. I mean, research is done on turmeric, but when your grandma tells you, turmeric is a natural antiseptic, we may not believe or we may not use it here. And for them, it was not because it was passed on, but that time they did not have access to allopathy. It's a different thing, either it extended or shortened their lifespan, but anyway. So, ethics toolkit 1 is that very important thing. The other thing is, part of this, because sometimes when you're also a writer, I'm also an extensive writer, so actually my words provoke when I'm not speaking much more. Okay, so I do not go with the idea of writing, or pitching a story, because I do journalistic writing as well. Yeah, I tend to just mix with the community. In the sense, with the queer trans people, there are people. But I've also written on workers' health issues, like, garment workers, what are their respiratory and dermatological issues. I've written on, I've gone to Niyamgiri, I've not gone to the Narmada protest site, but I've gone to, other resistant sites and all that stuff. So I've written from various angles. Don't go there because you're doing research, because you want to be one. Don't even go to say that I'm going to treat you. Okay, many times they will step back because of how bad the system is. So this is also something which you can build into your ethics, that is it possible to do that, What is ethics, right? It's a different kind of, an official way of, saying I've established trust and taken permission, right? That's also one thing, consent and all. So I think finally, socialization is a good form of not just building sensitization, but also maybe redefining your ethics, okay? Like, should I research for the sake of researching, or should I research because, like Dr. Nancy said, that it is going to be mutually beneficial. Yeah, I extend my body of knowledge and maybe my interventions, and the what is that? The communities may be benefiting, or they'll be teaching us something. Okay, thanks.
Anybody else who would like to? Yeah, please. There are two people. Let them listen to them.
I just have something to add here. Often when we, as queer individuals, we are even filling out forms, like even a simple form that says, there's the indicator that says gender. And just there in the options which are given, in the drop down, those are exclusionary. Like 90% of the time, we will not see ourselves, our identity reflected in that drop down box. And your gender question will probably be the third or the fourth question, right? From the beginning, first name, and then maybe age or something, and then there will be gender. And right there, we separate from whatever you are wanting to reach out to through that survey or that toolkit or that questionnaire. So, and obviously it's not, it's so inherently heteronormative to just write male, female, other, that we don't even realize that it's LGBTQIAP+. That's versus cishet, right? And all of those get clubbed into just the others, which is demeaning, it's disrespectful, it's marginalizing, it's just making us more vulnerable on that form itself. And we go through it repeatedly in every form that we fill. That makes us angry. Nothing else, just angry, just because our identities are not there. So, it starts from the place that, whenever we are creating a form, whenever we are trying to get information, we think less of it as taking information from someone else and trying to make that form itself a space where the other person can tell their story. Queer movement or queer pride thing is a umbrella. There is no fixated points that this is who I am, this is who I am. It's just an umbrella. So I think the first unlearning bit is to see it as fluid, and then create things around it.
Dr. Savitha, thank you.
It wasn't a question, but a humble submission that I'm fortunate that my talk was actually paired with this talk. Otherwise, I don't know whether I would have attended it. But I must mention that I'm really humbled to listen to your talk today, which gave me I think I can make out that my vision was more tubular, and it is sort of widening my field of vision. And I congratulate Nancy for having started this kind of collaborative effort. I don't want to call it research. I hope it becomes more of a collaborative effort from St. John's, and which would help actually make a difference and not just bring out a publication. So thank you very much for this, and I hope it grows forward.
Thank you, Dr. Savitha.
Anybody else Anybody else would like to say anything? Would you like to say something?
You can continue. I said my bit.
I don't want to make too many questions because
It's okay, doctor. You can.
no, I have been battling with what you are talking about it for a long time, for the last 30, 40 years,
I've heard
looking
you
at
on
it,
one
the
of
whole
your
philosophy of science and philosophy of social science is areas of my interest. One point that I want to make is about the methodology. Because what methodology you are talking about is emerged long back in early 19th century, the participatory we are talking about in social sciences, particularly sociology, early 20th century, not 19th century, when a lot of work on participatory methods had come up and participatory action research and all that come up. So it did come from the disciplines, and it was picked up by the feminist movement and then LGBTQ movements. This is how it happened. And LGBTQ movement had to fight against the feminist movement to create space. So I'm also witness to fight between feminists and LGBTQ. So because 80s was a major, 70s and 80s was a major upsurge of feminism in India, and I was witness to it, in my family is very strongly feminist. I learned from them.
I know about your family.
Yeah, so I am very, very, so that is one area, is a methodology. In medicine, normally we are positivists. And our positivism says that none of our bias should be reflected in our study. Because that, evidence-based medicine, that movement which came with, R.C. Cochrane, has created a huge impact, which which just marginalized the qualitative research. The BMJ, there were social scientists who have written a protest letter for not publishing any qualitative research there. Ultimately, they have now published qualitative research only in medical humanities. They are a separate journal, but they don't publish in British Medical Journal. Why? Because medicine is by definition, is supposed to be evidence-based, and evidence is only numbers. Where you do in experiments, observational is also low quality, evidence, and there's a hierarchy of evidence and all. Qualitative research they don't consider oftentimes research at all because you are in it, right? But the things are changing, and what I was it was heartening to see that you had a mixed method, and you also had a qualitative research combined with the quantitative research. In her study at here, and so that shows that there is opening for you, and there is a lot of hope. And as she said, that we should be collaborating.
Yeah.
Right. And the second issue that you raised is representation, which absolutely, not just for you, but also for the caste-based people,
Of course, that is what
the minority, particularly Muslims. That is another major issue that is coming up.
Were often further more marginalized. Yeah.
So this is definitely, I think, all of us who are in different committees or have a responsibility of forming them, they should be very, very conscious about it, and they should look for. Unless you look for, it's like research. In research, if you don't identify it as a research question, you will never find the evidence that you want. Evidence comes from your research question. What is your objective? So if you don't have this objective of getting, like this in IJME, Indian Journal of Medical Ethics, we had to go around to find LGBTQ people who were interested in writing, were interested in working in a journal setting, provide voluntaries. And people said that you won't get, but people were there, and they came and joined, and they started writing. Not only they, but they brought so many other people to write. Same thing is happening on caste issues. So it's not that people are not there. They're invisible because we don't see them. So I think...
Invisibilized, actually.
Absolutely. Thank you for this.
Thank you.
Yeah, thank you very much. It was a very enlightening discussion of all three studies, and I congratulate all the three participants for their excellent presentation. We now conclude this session, and before we do that, we'll give the...
You need to get a gift.
There is a QR code for the feedback. If everyone could do that for the second day, it will be nice. And I would like to call Dr. Amar to give away a token of appreciation to the participants.
You are